and share your...
Yes.
Just
assuming you can see these okay.
Perfect. That's absolutely
Great.
wonderful. Just checking that we've got most people back. Okay, so we'll make a start because obviously a 20-minute talk is still a bit of a rush. So thank you, Jai, for agreeing to speak. And again, it's a pleasure to introduce Jai Carmichael. And Jai, you're from Monash-Epworth Rehabilitation Research Centre at Monash University in Victoria, Australia. One place I haven't yet been, I'd love to go.
Unfortunately, yeah, not anytime soon.
No. And Jai, you're talking about the high-top model, which is the hierarchical taxonomy of psychopathology. And I will hand over to you. Thank you, Jai.
Thanks so much, Sarah. Thanks so much for having me as well. And this talk will probably be a little bit of a change of pace, but hopefully you find it interesting. And please, if you have any feedback, questions, reflections, you can reach me on Twitter or by email. But I just thought I would start by introducing myself. So I'm a PhD candidate in clinical neuropsychology at the Turner Institute for Brain and Mental Health at Monash University in Victoria, Australia. And I conduct my research out of the Monash-Epworth Rehabilitation Research Centre, or MERC, which is a collaboration between Monash University and Epworth Rehabilitation. So Epworth Rehabilitation is a large private hospital that treats 30 to 50% of all head injuries in our state of Victoria. And just to give you a sense, Victoria is the second most populous state in Australia. So we have around 6.5 million people residing within it. And my PhD research is concerned with the interface between traumatic brain injury and transdiagnostic approaches to mental health. So I just thought to begin, I ought to provide a brief overview of what traumatic brain injury is, as I appreciate audience members may not be too familiar. So traumatic brain injury refers to any brain pathology that's caused by an external force. The most common cause is a fall nowadays, but motor vehicle accidents also remain a major cause of head injury across the globe. Around 27 million people receive medical care for a TBI each year. And we're talking about a chronic health condition. So symptoms often do not ever completely resolve for individuals with moderate to severe TBI. Due to its high prevalence and chronic nature, it's really no wonder that TBI is estimated to cost the global economy $400 billion annually. So at the time of head impact, there are a combination of forces resulting in both focal and diffuse injury to the brain. And in particular, as the brain rotates on the brain stem, axons can stretch, shear, and even tear. And this disrupts connectivity within the brain. When someone sustains a TBI, there is a period in which they are unable to form new memories. And we call this post-traumatic amnesia, or PTA. And the duration of PTA is typically used to define the severity of the TBI. So most commonly at Epworth Rehabilitation, we see people with moderate to severe head injuries. So that is the duration of PTA is at least 1 day in moderate cases or 7 or more days in severe cases. The long-term consequences of TBI are wide-ranging, and they include impairments in cognition, emotion, behavior, and physical functioning. And these in turn negatively impact upon the individual's interpersonal functioning, their independence in daily living, and their resumption of productive activities. But why, as researchers and clinicians, should you be interested in traumatic brain injury? Well, first, TBI is not a random event. And in particular, various types of psychopathology, such as substance use disorders, and features of psychiatric illness, such as impulsivity, are risk factors for sustaining a TBI. When the TBI occurs, there are then neurobiological changes in the brain, but there can also be psychological trauma, grief, newfound functional limitations, and a reduced ability to cope with stress. And all of this can exacerbate existing psychopathology, but also most individuals with TBI at some point will experience novel psychopathology that they hadn't experienced prior to their head injury. So in essence, what I'm trying to say here is that psychopathology is overrepresented amongst those with TBI. And this has been packaged in a few different ways. So first in terms, pardon me, of neuropsychiatric symptoms. So you'll see whilst prevalence estimates vary, that difficulties with emotional regulation, behavioral regulation are both common, as are apathy, fatigue, sleep disturbance, cognitive impairment, and post-traumatic headaches. And psychopathology after TBI can also, of course, be conceptualized in terms of traditional formal psychiatric disorders as defined by the DSM or ICD. And research from our own center has found that 75% will experience a psychiatric disorder within the first 5 years post-injury. And most commonly, this is a depressive disorder, an anxiety disorder, or PTSD. So then one reason I think you should care about TBI is simply because psychopathology is elevated in this population. In addition, there has been a recent spotlight on diversity and inclusion within research on transdiagnostic approaches, and disability is a part of human diversity. So people with disabilities may have different mental health support needs and communicate these needs differently. Third, there simply aren't enough neuropsychologists and neuropsychiatrists going around to support all individuals with adjusting after a brain injury. So these individuals can present to any mental health clinic. Fourth, and what I will be discussing next, is that I think the TBI population is likely to benefit from transdiagnostic approaches. So our research center for around 15 years now has been conducting this prospective longitudinal study on the prevalence of DSM psychiatric disorders following TBI. And in doing this research, we have identified a number of shortcomings of traditional diagnostic approaches that you'll likely be familiar with from working with your own populations. So first, the rates of comorbidity between psychiatric disorders are high after a TBI. For instance, rates of comorbid mood and anxiety disorders are reported to be as high as 77%. Second, we see very high rates of not otherwise specified diagnoses in this population. So in our research, for example, anxiety disorder NOS was the most common anxiety disorder after TBI. So these findings suggest that the diagnostic approach may not adequately capture psychopathology as experienced by individuals with a TBI. So the limitations of categorical diagnostic systems would seem to underscore a need for dimensional characterization of a broad range of symptoms. And this could be achieved using clinical rating scales. However, what we have found is that for existing measures that we have for TBI, for instance, the hospital anxiety and depression scale, comprise a very dominant general distress factor. So these measures are unable to reliably pass general and specific components of psychopathology, which is necessary for adopting a transdiagnostic model. So what we need are broadband transdiagnostic measures that can yield reliable, homogeneous, and dissociable symptom dimensions. However, such measures have yet to be validated for TBI. Now, not only are traditionally defined psychiatric disorders incredibly heterogeneous, as you'll all know, but so is traumatic brain injury. And this reflects complex interrelationships between injury-related, but also pre- and post-injury factors. And these all contribute to recovery such that the type, the duration, the trajectory of symptoms can all vary considerably from one person to the next. And as such, we're really bad at predicting emotional distress actually after a TBI. So in fact, the severity of the brain injury, as measured, as I said earlier, by the duration of PTA, is actually not predictive of emotional outcomes. But other injury-related factors that may contribute to variable outcomes include the locations of injury in the brain, how far along the person is post-injury, what caused their injury, and whether there are also injuries to other parts of their body. There are also many pre-injury factors that may influence recovery from TBI. To name just a few: sex, age, ethnicity, genetics, cognitive reserve, and of course, pre-injury mental health. And lastly, post-injury factors such as the level of informal and formal supports available that can also differ considerably between individuals. So our current approaches to conceptualizing psychopathology following TBI are limited, and this has likely had consequences for the efficacy of treatments we have developed to date. Indeed, a recent report revealed that psychopathological problems were the area of greatest unmet rehabilitation needs for those with TBI. So with respect to psychological treatments, we've seen that psychotherapeutic interventions that address depression, anxiety, and somatization simultaneously have been more effective than those targeting depression alone. So these treatments that show promise may be targeting factors that transcend traditional diagnostic boundaries. And with respect to pharmacological management, well, 2 recent meta-analyses actually found that at group level, antidepressants were no more effective than placebo for depression after TBI. So in this case, we may be using a one-size-fits-all approach, that is giving all of these individuals the same antidepressant when they are really presenting with varied forms of psychopathology and varied forms of traumatic brain injury. So to conclude this section, the mismeasure of psychopathology and our inability to address the heterogeneity of TBI as well has likely meant we've had poor targets for the treatment of psychopathology, resulting in their persistence in this population. Moving forward, if we can leverage the shift that's been occurring in the broader field of psychiatry towards transdiagnostic approaches, then hopefully we can identify more homogeneous and reliable symptom dimensions of psychopathology following TBI. And these empirical dimensions may better align with genetic, neural, and other risk factors, and could therefore help inform prognosis, but also the development of more targeted and efficacious treatments. So what am I and my research team doing to this end? So broadly, the aims of our TBI transdiagnostic research are first to validate measures that have been optimized for transdiagnostic research for people with TBI, to then use these measures to develop one or more transdiagnostic models that are specific to this population, and then to leverage these models to map on associated factors. So we're sampling from a pre-existing longitudinal study, which recruits participants from TBI admissions to Epworth Rehabilitation, so a private rehab hospital. And we're sampling from any time point. So far, we have participants ranging from 1 to 34 years after their brain injury. To be eligible, individuals must have sustained a moderate to severe TBI and be aged 18 to 80 years. And we will also have access to a control sample of individuals without a history of TBI who are being recruited as part of another transdiagnostic study occurring in our university. So participants complete a battery of questionnaires designed to cover most traits and components of the hierarchical taxonomy of psychopathology. And aspirationally, we are also hoping to acquire funding for further components of the study. However, for today's talk, I will just focus on this first step. So really briefly, we're using the computerized adaptive test of personality disorders to tap each spectrum of the high-top model, the inventory of depression and anxiety symptoms to further characterize the internalizing spectrum, subscales of the externalizing spectrum inventory to measure alcohol and drug use, and the somatic symptom scale 8 to measure somatic symptoms. In addition, we have measures of functional disability and satisfaction of life. We will, of course, be characterizing our sample in terms of demographic factors, but also TBI-related factors, alongside self-reported mental health diagnoses and treatment. So these slides were made last week, but we've now had over 200 people with TBI complete the battery, and 2/3 of them are male, which is in keeping with the TBI population at large. They're aged on average 48 years. 3/4 have sustained what we consider to be a severe TBI. So this, if you might remember, means the duration of PTA is at least 7 days, but the median duration of post-traumatic amnesia in our sample is 17 days, so quite severe. Time post-injury is on average 10 years, but ranging broadly from 1 to 34, and 2/3 of the sample sustain their TBI in a motor vehicle accident. 40% of our sample have self-reported a current mental health diagnosis. 1/4 are currently on a medication for their mental health and or seeing a professional for emotional support. Interestingly, 6% have self-reported past year psychiatric hospitalization. And I think a really important preliminary finding of our study is that mental health has been the greatest area of self-reported disability amongst these individuals. So briefly, we will consider a number of empirical approaches to try to develop one or more transdiagnostic models. So we'll use latent variable approaches with a particular interest in fitting a dimensional hierarchical model akin to HiTOP. However, we will also consider whether we can identify any data-driven subtypes, clusters, or categories of psychopathology in the sample. And we will also explore a network approach to consider the interactions amongst individual symptoms. So finally, I wanted to discuss some of the practical and conceptual challenges that we've been facing doing this work. So there are quite a few challenges that we've identified, and because of time constraints, I'll just focus on the first three. So first, the cognitive impairments associated with TBI serve as a practical obstacle to having participants complete what is an hour-plus long survey on abstract concepts. In particular, difficulties with sustained attention and cognitive fatigue mean that participants may struggle to complete our long questionnaire battery. And some have even declined to participate because they didn't feel they could cope with the cognitive demands. So as a clinical neuropsychologist, we have made a number of accommodations to support our participants' cognitive difficulties. And these include the use of save and return functionality, very frequent reminders and prompts, and use of external aids. The next challenge, and perhaps most critically, is that symptoms of psychopathology overlap with the direct physiological consequences of traumatic brain injury. So this means that certain symptoms may be endorsed by individuals with TBI, irrespective of their mood. And so the structural relationships between symptoms may also be different in our TBI sample. So an example of this is the appetite loss and appetite gain HiTOP scales. It's often the case that TBI participants in our sample endorse appetite changes in the absence of any depressed mood or other affective symptoms. So explanations for this include that the olfactory nerve, which is important for our perception of smell and taste, is frequently damaged by TBI. And so for this reason, individuals may report less of an appetite. On the other hand, damage to the hypothalamus or brainstem, which is also quite common, can lead to overeating as the hunger signals to the brain have been disrupted. Another example would be with the lassitude and insomnia scales. So individuals with TBI may experience sleep disturbance and fatigue independently of their mood as a result of neurochemical changes stemming from brain trauma, such as growth hormone deficiency. Also, they might expend additional cognitive or mental energy in order to compensate for their cognitive difficulties, and this can lead to cognitive fatigue. So I do think that structural equation modeling will identify these and other instances of differing structural relationships within our TBI sample. And then we're planning on testing for measurement invariance as compared with the control sample. And what I'm expecting is that the latent variable structure of psychopathology between those with and without a TBI will be somewhat different. So lastly, another challenge is that we're seeing some evidence of potentially different response styles between our TBI and non-TBI participants. So an example is with the item, I feel exhausted. So looking at the raw item responses, the control sample shown in dark blue, which comprises mostly university students, is endorsing greater levels of exhaustion, which is not necessarily what we would have expected. So it could be that our TBI participants who have been recovering from a chronic health condition have a different perspective as to what constitutes moderate, quite a bit, and extreme levels of exhaustion. Alternatively, the phenomenology or lived experience of this item may be different. For students, extreme exhaustion could refer to burnout. For those with TBI, however, extreme exhaustion may be cognitive fatigue, where at its extreme stage, the person has to curl up in bed, they can't think, have a conversation, or get themselves food even. So we could use something like item response theory to test for differential item functioning between our samples. Although if students and those with TBI are actually rating a qualitatively different experience, then maybe it's simply not appropriate to compare scores. At the end of the day, it's not a competition as to who's more exhausted. Rather, the goal of this research is to map the structural relationships between symptoms in TBI. So in conclusion, hopefully I've made the case that individuals with TBI experience elevated rates of psychopathology. If you work clinically, I think you should probably be checking if your clients have a history of head injury. Transdiagnostic approaches do show promise for improving the lives of individuals with TBI, however, yet to be used. And there are a range of practical and conceptual challenges to doing this. So in particular, the structure of psychopathology may be different in those with a TBI. And so we shouldn't be generalizing models that have been validated in other populations. Thank you very much for you guys for listening and the people and organizations shown on the slide.